On I go, new stuff. Okay, so I'm going to just run through some things. This is Revlimid or lenalidomide in newly diagnosed myeloma. So this I mentioned is not funded in Australia yet. But it's a highly active therapy. So a trial was recently presented just in December at the American Hematology meeting comparing lenalidomide, also known as Revlimid, plus dexamethasone, with melphalan, prednisone and thalidomide, another standard treatment, if you like. And so what happened was this is a clinical trial which Australia participated in, and there were a few sites in Brisbane that participated in this study. Patients either got MPT, melphalan, prednisone, thalidomide, standard treatment, or they got lenalidomide and dexamethasone, which just kept going until the myeloma came back or you got side effects, or they got the lenalidomide and dexamethasone for 18 months, a year and a half, and then it stopped. And in fact, this arm here was closed because the results showed that the myeloma started to come back quickly after you stopped the lenalidomide. So it kept on with these two as a comparison. So lots of countries, you can see this international, a lot of countries in Europe. I don't think there's anyone in Ayers Rock, but I think there were quite a few sites, about 12 sites in Australia, I think, that participated in this, New Zealand, and a few sites in America as well. So a big international effort. At the time, the largest trial ever in myeloma, 1,600 patients. I won't go on about this. So these are the results. This is what they call progression-free survival. So this is the duration of time that the myeloma is kept under control. And the Revlimid and dexamethasone, you can see 3 years down the track, 42% of patients, their myeloma hadn't progressed if they got that, compared to melphalan prednisone, 23%. So a 20% absolute improvement in the control of the myeloma. And these are the survival curves. They're not as dramatic, but the two to look at is the green one and the white one. And if you look at 4 years, which is the 48-month time point here, you go from 51% of people being alive to 59%. So about an 8% improvement in the number of people alive. So in the US, this is a standard upfront treatment. If you've got insurance, of course. If you haven't, you get nothing. But in Australia, I guess we'll see if the government wants to fund it. It's highly expensive, and they'll want to know whether it's worthwhile. The other issue is that at the moment, this is the first, what they call an interim analysis. That is, it's not the final result of the trial. And sometimes results can change between the first time you look at the data and the second time you look at it. But nonetheless, looks like a very effective treatment. Side effect profile is quite good. The other drug that might be not too far away is Pomalidomide. This is the next generation of the thalidomide, lenalidomide family called Pomalidomide. Probably the most potent of these drugs at getting myeloma under control, and probably, I think, less side effects than lenalidomide as well. In Australia, I think we had about 6 sites or so, including some in Brisbane, with a comparison of pomalidomide with dexamethasone versus dexamethasone alone. This was a trial for patients who had failed standard chemotherapy, failed Revlimid or lenalidomide, failed Velcade or bortezomib. So patients for who we had no good treatment options. And what's happened in this is that you can see clearly if you get the pomalidomide, the control of the myeloma is better and people are surviving more. So this, in fact, they had to close off the dexamethasone-only arm and allow everyone access on this trial to the pomalidomide because the results were so clear. Again, the difference in survival is not huge. This is in months here, if you like. But at the end, when you've had lots of treatments for myeloma, sometimes several months can be very important to a patient. It's also clearly active when nothing else works, so almost certainly it'll be moved earlier on in the myeloma management. Yep.
What role does interferon play in relapse?
Oh, look, now very little. Yeah, so it used to be used when we had just chemotherapy, so it has got activity. It can control myeloma. If you give it just by itself, the response rate's about 20%, whereas, for example, if you give Velcade by itself, the response rate's about 60%. So it's nowhere near as effective as these newer agents, and its main problem and why it's lost favour as a maintenance strategy to keep the myeloma away is the side effects of interferon. So in most of the trials, about 3/4 of patients couldn't stay on the interferon because of side effects. Look, it's something you could try, but I wouldn't say it's vanished, but it's used very infrequently now. Yeah. Whereas when we had none of these newer agents, it was moved to a little bit. The issue with myeloma now is that by the time it's broken through all these treatments, it's behaving in a really nasty, aggressive fashion. Interferon needs time to work, so it's not often suitable in that. Another drug, Carfilers. So this is the new generation of Velcade type drug, and it's again very potent. Its main good point is that it doesn't affect the nerves like Velcade does. It's got a very low rate of nerve toxicity. So in fact, in these studies that they looked at, several studies involving a few hundred patients, only 6 patients, that's 1.2%, got a severe peripheral neuropathy event, whereas for the Velcade studies, that's typically around 20%. So that seems to be a major advantage of this drug. In fact, you can see here, in this pie graph, the blue is those that didn't have any nerve problems. The red is those that had very mild nerve problems, and the 1.2% is the severe nerve. That's like nerve pain. So it seems pretty good from that point of view.
Doctor, did you say these new drugs are only available to newly diagnosed?
No.
Oh, okay.
No, what I'm talking about at the moment is not funded in Australia at all, but hopefully it's coming. These are the drugs that are closest to coming, if you like, as opposed to the media breakthrough that you hear about every couple of weeks. These are drugs that have advanced through early phase. They've started in animals. They've gone through early phase trials in advanced myeloma. They've been moved up earlier and earlier as they've been shown to be effective.
So would you think 5 years, or can you guess how long before they?
Yeah, I think a couple of these within 5 years. It'll depend. The federal government's budget doesn't sound like it's in great shape at the moment, so that may or may not cause problems. I don't know. And I've been mentioning that people in Australia have had access to these drugs through trials, and typically there are a lot of patients have a lot of fear about clinical trials, but I must admit, with most of the trials, there's advantages to being on them. One is that you are forced to get the best possible care because you have to follow the protocol. So there's no room for someone doing something that's a little bit unusual. These randomised trials are comparing one standard with a new treatment, which both know they work, for instance. So there's no way you're going to get a dud therapy. It's different if you're in a trial that's trying something for the first time. In that situation, there is an experimental element to it. There's also been a lot of work done, mostly in kids and in breast cancer, that shows that people on trials have better outcomes, even though they go into it with exactly the same disease. So, there's a lot to be said for going on a well-designed medical trial. So here's Carfilers. So this is advanced refractory myeloma, where normally the response rates would be 10% or so, and this ORR, overall response rate, so 53%. Okay, so about 53% responded. So about half of people's myelomas responded when maybe only 10% was expected to. So clearly a highly active drug. So I'll just present this data. This is Carfilers, lenalidomide, or that should say dexamethasone. So we haven't got this funded, we haven't got this funded. Without, if you had to pay for the drug, this is $120,000 a year, this is similar. So these drugs are highly expensive, which give you an idea of why the government's not rushing to fund them. So, you know, two highly expensive drugs together. So this combination is not going to be coming to Australia anytime soon. But just to show you what can happen, these are patients, so they got 4 cycles of this drug and then they could have a transplant or they could have more, and they got the Revlimid after you've got a good response. So the Carfilers is intravenous, the Revlimid and dexamethasone are tablets. But everyone's paraprotein responded very rapidly within the first 2 cycles, so really very quick. And so after only 2 cycles, the average reduction in the myeloma protein was 80%, so that's highly active treatment. And then in this case, you can see this is stringent complete remission. This is where we can find, even with a more sensitive test, no evidence of myeloma in the body. 42% could find no evidence of the myeloma on extra special testing. So this is a highly active combination in myeloma and shows what can be achieved. The Italians have looked at this drug with cyclophosphamide in older patients with myeloma, so over the age of 65, so people not having a transplant. And just to give you an idea of how effective this drug looks, here we've got the Revlimid dexamethasone, which we just showed you, looked better than the melphalan-prednisone thalidomide, and we got the other popular regimen, VMP. These get really good responses, you know, in 40%. With this Carfilers combination, it's up to 77%. After 2 years, you know, 13% of people are no longer alive, compared to about 20-25% with the other combinations. So better control of the myeloma with highly effective drugs means less chance, obviously, of dying from myeloma. So the new drugs are very potent. The combinations, I'm sure, will work, but a big factor as well in the future is going to be how is the Australian government going to afford highly expensive medicines, let alone combinations of highly expensive medicines. And the other good thing about this combination was that the side effects were very low. So only 14% of people had to stop their treatment on this study, compared to about a third in the other trials, and they're stopping because of side effects problems. So no peripheral neuropathy, no clots, only 4% had low platelets. So good not only in terms of being effective, but it looks like the side effects profile is very good. The next drug is, it's got a funny name, Accessor Mabh. It's a tablet Velcade. So as opposed to having to come in and have an injection, you can take a tablet once a week. And again, it's advantageous in that it seems to cause less neuropathy, but it does seem to cause more rash and diarrhea. And again, this drug has been trialled at several centres in Australia, again including Brisbane. This was a study which I'll just show you. This is what they call a waterfall plot. So this is everyone's myeloma protein. If the bar is going down, your protein is getting lower. If the bar was going up, your myeloma would be progressing, your protein would be going up. So you can see no one is progressing. Everyone's myeloma protein is coming down. This is 100% decrease down here. So half of the people on this study, their myeloma protein's gone. Nearly everyone, there's only one person here whose myeloma protein didn't reduce by more than a half. So again, a highly active new drug. The next couple I'm going to talk about briefly are probably where there's a bit of excitement. These are antibodies. So antibody treatment against the myeloma. So this one's directed against something called CD38, which is on the surface of myeloma cells. In fact, when we do a bone marrow, this is how we identify, one of the things we use to identify myeloma cells. So they've developed an antibody to latch onto the surface of the myeloma cells to activate your immune system to attack it. So this was an early trial that was being done where the antibody was given by itself, so with no other chemotherapy, and you can see that in people whose myelomas come back, probably about 2/3 have got some sort of response, some sort of reduction. So as an antibody treatment, that's actually quite active. And this is where it was combined with the Revlimid and dexamethasone another one of these plots showing that everyone's protein is going down. In fact, I don't have the updated slide, but no one has progressed while receiving this combination. So it's highly active, and the advantage of the antibody is there's almost no side effects, it seems, from the treatment. There's another one called Elotuzumab, which only yesterday received FDA, that's like the American Drug Regulatory Body, approval to use in myeloma that's come back. It's against something called CS1, which is also expressed on the surface of myeloma cells. So another antibody treatment that's in fact out of the trial setting and into availability in the US. Someone asked me about this one. Got a bit of press a couple of weeks ago about a solvent that seems active in multiple myeloma. So in fact, this guy is a hematologist in Melbourne who was doing some myeloma experiments. And whenever you do an experiment, you put the active thing in one tube, and in the other you put nothing, except the nothing in this case was a solvent, and the myeloma cells died when the solvent was put in there. And so that led, you know, like it's a solvent as in paints and stuff. So that led to a bit more research, and it's interesting. It seems to kill myeloma cells and also improve immune function. That's in rats, though. It's never been given to people. And so they're going to start a trial. I was talking to one of them on the weekend. They're going to start a trial towards the end of this year to see whether it's safe and whether it's got any activity in treatment. This is what I'd refer to as the weekly myeloma breakthrough or the weekly cancer breakthrough. I mean, it may come to nothing. It may be highly active, but it's going to be years before we know its true role. No, look, it seems to not kill. They've done toxicity studies, so they've done stuff to show it's safe to give to people as far as can be told. So it doesn't seem to kill off your normal blood cells, doesn't seem to be toxic to your brain. The mice, at least, don't seem to be having any major side effect problems. So that... It sounds funny, but there is a series of, in fact, it's a very long series of steps which you have to show before you can give a drug to a person. And there's a whole range of things that the government requires to be shown. So, but nonetheless, animals are not people, and some things show up in people that are not obvious in...
Can't really ask a mouse if he's feeling better.
No, can't. You can only tell if he's lost weight or he can't walk. Anyway, so this is my last slide. This is a list of, this is just something published recently, but a list of drugs currently under investigation in myeloma. You don't need to read it all, just to get the impression. There is a lot of active drugs that are being trialled in myeloma, and these are just the ones that are in clinical trial. These are not the ones that are just in the lab still, like that previous one. So, and in Australia, there's probably currently about 20 different myeloma trials open, looking at different strategies of treatment. So I think there is a bit of hope. In fact, there's quite a bit of hope, I think, in the future. And but it's going to be a combination of finding the right schedules and drugs, and of course, can we afford the drugs is always going to be a big issue. That's all I've got. Thank you.